Hi, I'm Kmills. I'm an RN to BSN student at Morehead State University. Today I'll be presenting my Capstone project for Advanced Nursing Practicum. The topic I have chose is reducing readmission rates for patients with congestive heart failure. I chose this topic because I did my practicum with the case manager. At the facility where I did my practicum, the role of the case manager was to reduce readmission rates in patients with COPD, pneumonia, and congestive heart failure. Specifically, I chose congestive heart failure because Medicare is no longer reimbursing hospitals the cost of readmission if it occurred within 30 days of discharge. With that being said, the key objectives for my capstone project was to review current nursing research articles and determine what positive interventions are out there to reduce these readmission rates. In addition to this review, I wanted to identify two QSIN competencies and how they are related to reducing readmission rates in patients with congestive heart failure. Also, I identified a case exemplar from my practicum. This patient was someone who was constantly being readmitted numerous times a year for congestive heart failure. Although we had already decided on what interventions to use for this patient, we were able to determine the similarities between our interventions and the interventions decided by studies performed by nurses. From these studies, I determined 4 specific interventions being used to reduce readmission rates in patients with congestive heart failure. These interventions included heart failure rounds, telephone follow-up, risk factor identification, and outpatient education. These articles recommended heart failure rounds by using a physician, nutritionist, pharmacist, and a nurse. This team would go around to patients with congestive heart failure while they were still in the hospital and discuss current needs and the plan of care. This allowed the patient to ask questions before they were discharged and assured that there was a great understanding of how they were to be treated outside of the hospital. The goal of this was to also reduce readmission rates. And from studies, this is shown to reduce costs by $500 per patient because patients were not being readmitted within that 30 days. Telephone follow-up either involved a nurse or a counselor calling the patient once they were home, and they were either giving a questionnaire or they were just questioned by the nurse how they were doing with their illness at home, to making sure that the patient had the right medications, that they were able to get to their follow-up appointments, and that they had no other questions. The third thing that we could do was outpatient education. A lot of times patients would go to clinics where they would see a counselor where they could discuss any concerns, if they felt that they were getting worse while they were there, and so they could also seek treatment before they had to be readmitted. Maybe in these instances the patient just needed an increase in Lasix so they could breathe better and get some of the fluid off before that their illness became exacerbated. So that was one other option we had found. The last option was risk factor identification, and this involved deciding who was at the greatest risk for readmission upon discharge. This would involve looking at what kind of resources they had outside the home. Did they have supportive family? Did they have transportation? Were they able to prepare meals for themselves, or did we need to get someone out there to bring them meals, like Meals on Wheels? Also, we would look at weight, like do they have a scale at home? Are they able to weigh themselves? Do they need home health? So this was another intervention that we could use while they're still in the hospital to prevent readmission. For my case exemplar, we were able to use all 4 of these by doing our heart failure rounds while they were in the hospital. Currently, our TCU unit, if we have a congestive heart failure patient, then they are seen by the heart failure round and determined if they're appropriate to be seen every day until discharge, where they are able to ask questions to either a pharmacist, nutritionist, case manager, the unit manager, or a nurse practitioner. We also have a heart failure clinic where we schedule an appointment for follow-up within the first week of discharge. Most people are not able to get an appointment with their cardiologist within the first week of discharge. So this is to assure that the patient is continually getting treatment after discharge and not being readmitted if their illness exacerbates. Also, we do the telephone follow-up. Our case managers call the patients preferably within 2 days of discharge. Unless they have an appointment that day, then we call them the next day. So we have that as well. And this patient seemed to do quite well. We did have to provide a scale because the patient was not able to perform that. He did not have transportation, so we were able to arrange transportation for the patient. And then he also didn't have many family members, so we were very sure to follow up with him a little bit more often. Although he did not get readmitted within the 30 days, he was not completely compliant with care. He did not weigh himself every day, even though we gave him the resources to, and we did follow up with education to remind him. He just said he was forgetful, but it was better than him not weighing himself at all if he weighed himself every 2 or 3 days. So we consider that to be a success as well. So my goal of this presentation wasn't really to look at my case exemplar, but really to look at current nursing research articles and determine what interventions are out there that are showing to be effective in treating patients with congestive heart failure and reducing their readmission rates. So we did do that as well. And we identified the 2 QSIN competencies, and these included patient-centered care and quality improvement. And I believe this is related to reducing readmission rates because we are doing patient-centered care by going around them, making sure that we're calling them, we're getting their input through the heart failure realm, and it's also quality improvement. We're making sure that the patient has the best care possible. So this was my presentation, and I thank you for listening.